All right, so thank you so much for joining us for this special session. It is so great to see so many of you. I'm Raynell Lang. I'm an infectious disease physician and epidemiologist from the University of Calgary, and also the assistant medical director of the Southern Alberta HIV Clinic. And so I have the honor of introducing this special session that's titled Approaching Transnational Collaborations Amid Shifting HIV Funding Priorities and Global Geopolitics. I'd like to start with a land acknowledgement that this talk is being on the original lands of the Anishinaabe, Inninewak, Anishinaabe, Dakota Ayote, and Dene, and Inuit, and on the national homeland of the Red River Métis. We respect the treaties that were made on these territories, we acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. I have no conflicts to disclose. So I'd like to start us off by providing a little bit of background to contextualize this panel. And so I know many of you already know what PEPFAR is, but for those who don't, PEPFAR is the President's Emergency Plan for AIDS Relief. It provided HIV services to over 55 low-middle income countries globally and was representative of 80% of all international HIV donor funding. PEPFAR supported antiretrovirals for over 20 million people living with HIV and provided PrEP for over 2.5 million. Estimates suggest that over the past 21 years, PEPFAR has saved 26 million lives and prevented almost 8 million perinatal HIV infections. However, unfortunately, in January of 2025, the new administration ordered a 90-day hold on PEPFAR programs, and this was extended several times. USAID is the implementation agency for PEPFAR, and this has been dissolved. And therefore, PEPFAR's implementation capacity is essentially eliminated. In July of 2025, reports disclosed a plan to further cut PEPFAR funding by over 40%. More recently, this is looking like around 55%. And this is all to say that the future of PEPFAR remains very uncertain. There have been some excellent modeling studies to try to predict what these funding cuts may have impacts on in regards to HIV new cases and global deaths. This is a study that was published in Lancet last year, looking at 26 PEPFAR-funded countries, and the nice trajectory down of panel A is the new HIV cases, and the purple shading is what we might expect in the next few years with PEPFAR eliminated. The panel B is the number of HIV/AIDS-related deaths. And again, it was nicely declining. However, the purple shaded is what we might be able to anticipate with PEPFAR eliminated. I want to highlight an ancillary event that we hosted on the 23rd of April, so the first day of CAHR. This was an event where we started to be able to have these conversations of what does the cuts in HIV global funding have on impacts in Canada and Canadian HIV epidemiology as well as care. This was hosted by the Canadian Strategic Consortium to address the changing policies and environment of global HIV care. And I want to thank you so much for everyone who came out and made this a very successful event. And for those who were unable to attend but want to join us for future events, please feel free to email me, as this will be an ongoing conversation with lots of work to do. So, with this panel, the decision to withdraw funding has the potential to irrevocably undermine HIV programs and forever change the course of the epidemic. Programs face difficult decisions with calls to integrate HIV services into wider healthcare systems amid diminishing resources. At the same time, communities most affected by HIV are facing shifting legal and policy contexts and rising criminalization, with increases in laws attacking the rights of 2S LGBTQ+ communities globally. We want to welcome you to the special session, which aims to explore Canada's evolving position in global health collaboration from funding, research, policy, and program perspectives. Amid ongoing defunding, in HIV programs and shifting geopolitics, what possibilities can Canada explore in approaching transnational collaborations in global health? And I just want to highlight a quote that I think so nicely will start to summarize some of the discussions we have today. It is so easy to break down and destroy. The heroes are those who make peace and build. And so with that, I would like to introduce our panelists, and we can hopefully start on this discussion to make peace and build. So Dr. James Blanchard is a professor and the executive director of the University of Manitoba's Institute for Global Public Health. He holds a Canada Research Chair in Epidemiology and Global Public Health. Over the past 25 years, he has provided leadership to the design and implementation of large public health programs related to sexually transmitted infections, HIV/AIDS, maternal, neonatal, and child health in Canada, India, and Asian countries and Africa. He is actively engaged with policymakers and public health leaders to translate scientific knowledge and approaches to improve the effectiveness and efficiency of public health programs, with an emphasis on improving the health of disadvantaged populations. Professor Linda Gale Becker, happy birthday, is the Chief Executive Officer of the Desmond Tutu Health Foundation and Director of the Desmond Tutu HIV Center at the Institute of Infectious Diseases and Molecular Medicine at the University of Cape Town in South Africa. Professor Becker is a physician, scientist, and infectious disease specialist. Her research interests include programmatic and action research around antiretroviral rollout and TB integration, prevention of HIV in women, youth, and MSM. Professor Becker serves on numerous international scientific and advisory committees. She is an A+ rated scientist and has published over 700 peer-reviewed papers. Sandra Kahan-Chu is a lawyer and co-executive director of the HIV Legal Network, where she works on HIV-related human rights issues concerning prisons, harm reduction, sex work, and immigration. She has helped guide the Legal Network's litigation in key court cases in Canada and internationally, including lawsuits challenging the Canadian government's failure to adopt prison-based needle and syringe programs and criminal laws governing sex work. Dr. Robert Lorway is a professor at the College of Community and Global Health and the Institute for Global Public Health at the University of Manitoba, where he holds the Canada Research Chair in Global Intervention Politics and Social Transformation. His research concerns with the social study of global health interventions designed to improve the lives of marginalized populations in Africa and Asia. Theoretically, his work attempts to understand how contemporary global health interventions enact forms of governments that shape new modalities of citizenship and make up communities with subjectivities for health service delivery schemes. His theoretical engagements are firmly rooted in collaborative public health projects conducted with members of community-based organizations. And I'd like to introduce the moderator for the session, Dr. Lisa Lazarus. She is an assistant professor in the College of Community and Global Health and the Institute for Global Public Health at the University of Manitoba. She is a critical social scientist with a focus on community-based research methodologies in the field of HIV sciences. She is particularly interested in how we further democratize community-based research partnerships across disciplines. She has been collaborating on community-based research since 2009 in partnerships with community-led organizations in Kenya, India, and Canada. Her research critically examines how we define success in global public health interventions, as well as significant role that communities themselves play in making success. So thank you so much for joining. I'm very excited to hear everything this panel has to say. Thank you.
So as the moderator, Jamie, I will welcome you to present first, please.
Thank you. There we are. Can you hear me? Okay. So it's a pleasure to be here. As presented in the introduction, I've spent quite a bit of my time in HIV programming, beginning in Canada, and then after that, more in other parts of the world. where resources were in some ways more limited, in other ways they were actually better. But for the last 5 to 7 years, I've been focusing more on other sectors, and so I feel a bit like a dilettante here today, but also perhaps bringing in a little bit of perspectives that I've learned about the HIV programming and where it fits into global health priorities, and where and how that might impact our discussion today and going forward. So there's my conflict of interest disclosure. Nothing to disclose. Okay, so when I saw the title of this session, where we talked about shifting HIV funding priorities, the first thing that came to my mind was that this is actually not new. 8 years ago, I think, I gave a talk at the IUCD meeting in Dublin where I talked about what happened to the other 90s. I'll address that a little bit more. But historically, global HIV programs were groundbreaking, and they were comprehensive. They addressed human rights, power, along with a range of prevention and treatment modalities. And they really were different than almost any other kind of a health program in any country in which you found them. But the HIV funding priorities really started shifting, and it's more than a decade ago. It's not a recent phenomenon. Treatment access became focused more on treatment as prevention, and increasingly towards what is essentially test and treat. And so, as I said, the question arose, what happened in the other 90s? Access to prevention, community mobilization and support, addressing stigma and legal rights, access to social entitlements. These were changed. The funding priorities for HIV programs changed and diverted resources away from these really critical parts of HIV programs, and that's not something that's particularly new. The other observation is that globally, there's been a huge emphasis on health system strengthening outside of the HIV program domain. But integrating HIV into health systems has come very late, and in many cases hasn't really begun much at all. And this has really been driven largely by HIV funding realities. But it's from the health system strengthening domain, it's seen as a bit of a marginal component. Yes, HIV also needs to be integrated as one of the many diseases that have to be integrated into our health system strengthening, whether it be in community processes, primary care, or facility care. So if we think about if we think beyond funding, it's hard to think beyond funding in these days, but if we think beyond funding and reimagining HIV programs, HIV programs developed principles, innovations, implementation processes, and expertise that could really help to address many of the growing health inequalities outside of HIV per se. HIV developed remarkable, innovative ways of reaching underserved communities, navigating syndemics, especially in complex urban environments. You won't find public health programs outside of HIV programs that have really been able to navigate complex urban environments the way the HIV programs have been able to do. But as HIV programs and services became narrower, they continue to become narrower when they could have become more comprehensive. So rather than expanding our HIV program platforms, which are reaching a lot of marginalized and stigmatized communities to include reproductive health, maternal and child health, TB and other infectious diseases, or even integrating other social programs, the HIV programs actually have been narrowing for quite some time. Looking forward, and we've talked about this, and this is not a new idea, but lateralizing HIV programs could address some of these constraints. And by lateralizing, I think of it in two ways. One is to lateralize the range of services that are available through HIV program platforms, whether they be community platforms or service delivery platforms at a primary level or otherwise. They could be utilized and leveraged for a wider range of things. I recall probably 15 years ago, maybe even 20 years ago, there was a really unique program in Lahore, Pakistan, which had been set up as a program for women in sex work in Lahore, but they had expanded and they were now providing a lot of services for other women in the slums who didn't have access to reproductive health, didn't have access to family planning, didn't have access to screening and treatment for STIs. So they were using the services that had been established. Now, if you look at programs for sex workers in Lahore, those community-based resources are being replaced by vans that are driving around looking for people to test. And so I think we really have to think about what the resources were, the models that were there before, and how we've changed them ourselves. And then I think, so lateralizing HIV programs to address the needs of other communities, I think is something we can look at. So a little bit of a sharper question: can Canada and Canadians play a central role? Well, we have some really key constraints, and some of them are beyond our control, but some of them are things that we've created ourselves, we meaning the HIV research and program community. So first of all, I think we have to be cognizant of the fact that Canada is a pretty limited global funder. If you go to most countries, the source of funding, the amount of funding that Canada is providing is really quite limited. And even if you look at the Global Fund, where Canada puts a lot of its funding, it's well less than 5% of global HIV funding. But we compound our problems by being highly fragmented. We're a very fragmented community in terms of the research, the implementation we do, and the policy work that we do, particularly globally. It's really a patchwork of individual projects, often driven by individual researchers or investigators. And I would say that if you look at Canadian research funding, this is a broad theme. It's not just around HIV, and maybe less in HIV than others, but there's an increasing inward focus. And if you get a sense from our new Prime Minister, who's been lauded for a lot of his response to Trump, but one of his responses has been, we need to focus on Canada. We need to protect Canada. And this is now being seen in a lot of the major funding initiatives in Canada, where there's an explicit question in most of the major funding initiatives. And that question is, how will this benefit Canada? And if it doesn't benefit Canada, you have a very high bar to get past if you want to get substantial funding in Canada. But there are also opportunities. I think we can build on Canada's considerable but fragmented strengths. There's been a strong history, and there's still a strong core of community leadership. Interdisciplinary research has been a strength of Canada, and Canada generally has operated with in our global health work with a high set of principles in terms of partnership and ethical work. I think there's an opportunity in Canada to develop a much more transdisciplinary research model. Though we do have a lot of investigator-driven research, we have a lot more hard funding in Canada for our researchers, which should allow us to reach across disciplines and work as teams, and yet we still sort of go. We still often work according to models that are more similar to the NIH-supported model, which is built a lot on soft funding. And I think we can also lateralize to integrate a wider range of health system initiatives, because Canada does have a history and a perspective around integrating and integrated health systems. So how? How can Canada do this? Well, I think it's a really good question. And rather than looking outward, I think coming from the academic sector, I think there's some really serious questions we need to ask ourselves. So those of us in the academic sector and those that fund the academic sector for our research, we really need to play a key role. But this will require some fundamental restructuring within the academic sector. First of all, we have to change academic incentives from individual achievement to collective accountability for outcomes. We still have an academic research model that is highly focused on individual achievement, individual trajectories, and then we ask people to work as teams. There's a cognitive dissonance there that we have to address. So academia has to really address these skewed incentives. We need to change our funding models. We need to have a better integration of funding for programs and service delivery and research with longer time horizons. And we need to look more at transnational partnerships that are not transitory. They have a longer timeline, and they're not transactional. They're not there as long as we have our grant, but they're built on a longer-term partnership, and they don't evaporate as soon as the CAHR or other grant ends. So we have to develop these longer-term initiatives. So I'll yield my time and look forward to the further discussion.
Thank you so much, Jamie. I think that gives us so much to reflect on, and I think starting with the historical lens is just so relevant to the conversations and themes we've been hearing over the last couple days about not wanting to go back to where we were, but what are the lessons that we've learned over the last 40 to 50 years about community interventions and more broader approaches that we can apply in this critical moment. So we're going to leave questions to the end, so Linda Gale, I'll invite you up next.
Thanks, Lisa, and thanks everyone for having me back again. And I'm really honored to be part of this panel. So I'm going to take, I really can't describe what Canada should do. I'm not in any position to do that. So I thought I'd take a broader sort of looking in at being a country that has received foreign aid, and then some of the lessons we've learned, and maybe then reflect about some of the reading I've been doing around global health and the changes that we are undergoing at the moment. So those are my conflicts. They haven't changed since this morning. This is something I wanted to start with. Reynal ended with something Nelson Mandela said, but he closed the 2000 conference in Durban, and he said at that conference, we need African resolve to fight this war. And he pointed out that partnership with the international community is vital. A constant theme in all our messages has been that in this interdependent and globalized world, we have indeed again become the keepers of our brother and sister. And that's 26 years ago. And obviously a lot has changed in those 26 years, but I think there are still some very important themes within that. I showed this morning that the time of that Durban conference was at a time that the newly democratic South Africa matured the largest HIV epidemic of any country in the world. Inattention and then intentional neglect due to an administration in HIV denial, South Africa became the epicenter of an epidemic that firmly and largely entrenched in East and Southern Africa. And death and destruction followed, and followed in a tsunami. It was not the infirm and the aged that were cut down, but young adults in the prime of their lives with consequent societal instability. Issues of stigma, discrimination, inequity, and access have plagued the response from the get-go, giving rise to an unprecedented, and I'm going to make this point again because I think it's important, and critical characteristic of the HIV epidemic, the civil society response. That passion has been the engine driver of the AIDS response from the beginning.
We have to speak to government when it is willing to work. We have to march when government doesn't listen. When they don't listen to our marches, we take them to court. And one thing, I don't think she said this, but maybe she did. In 12 years of TAC, we never threw a stone.
Activism and advocacy were interchangeable, and people stepped up, showed up, stayed up, and never gave up. Advocates have held fast onto their resolve that no one should be left behind and that all deserve the best and most respectful care, treatment, and prevention. And I've never seen this in any other field of medicine. It was against this backdrop that the global public health organizations rallied, institutions, funds, foundations were formulated, run from central locations, mostly Geneva, Guided and encouraged by the WHO and UN, countries contributed generously to avert the regional emergency, an international gift which brought life, but also restored stability, community cohesion, security, and was quietly loud diplomacy. It has been an astounding 25 years. Billions of dollars have been spent and impact has been realized. AIDS-related deaths have reduced by 54% across the globe, with the biggest gains in Africa. With 31 million people having accessed life-saving antiretroviral therapy, we can talk about being in the last mile of the epidemic. Despite these victories, all the 2030 goals set for the HIV response period will be missed. This creates real risk that the epidemic in many regions will become endemic, smoldering on for decades with the constant threat of outbreaks, continuing new infections, AIDS-related deaths, and ongoing TB co-infection. And the last mile can often be the longest mile, the most complex and critical. As new infections reduce, we must reach further to find those who have not easily stepped forward for prevention or treatment. As the years roll on, retaining millions of people consistently in care is challenging to health systems and treatment and prevention funds. The late Jonathan Mann, who had established the WHO Global AIDS Program and Project CAHR in Zaire, said the following in 1987. AIDS remorselessly highlights and exposes the weaknesses, the inadequacies, and the iniquities of our existing health and social systems. Prior to the acute shocks of 2025, with funding flatlining, as Jamie said, and PEPFAR ructions during the first Trump era, the International AIDS Society convened a commission with the Lancet to explore a more sustainable future of the HIV response in solidarity with the global health community writ large, and encouraged increased integration at local levels. We have still some way to go to achieve this. However, there were lessons learned. We can learn from more than 40 years of the HIV epidemic so far that are really instructive for this time. At a global level, and these are my thoughts, there is merit in global solidarity and global coordination. Global partnerships are key, but so is national sovereignty. That novel funding mechanisms at international and national level can be critical, especially in times of emergencies. Surveillance, epidemiology, and data matters. Heterogeneity means one size may not fit all. Scientific innovation is best sought through international and regional collaboration, and technical investment in determinants of health and system strengthening ensures resilience and sustainability. Making life-saving technology equitably accessible is a benchmark we should all aspire to. Then there are some lessons at a local level. Community-led responses are absolutely essential. Protecting human rights is a public health imperative. Multi-sectoral and political leadership, a whole of government and whole of society approach has worked. Harm reduction over risk elimination is to be sought. Data-driven and localized action, know your epidemic and know your response, is still an adage we should hold on to. Reliance on international aid is risky and unpredictable. Strengthening health systems is a sustainable investment, and we'll need new financing for this. And local expertise often generates the most effective interventions. Randall Packard, in his book, A History of Global Health, critiques that in the past era of global health decision-making, these occurred in places that are distant from where projects are implemented. Accountability goes upwards and not downwards. There is a lack of attention to the economic and social determinants of health. Globally, we have seen a rupture in the world order as global health and health in general as a basic human right is overshadowed by many other issues, including a wave of anti-science ideologies. A number of groups are looking at the global health architecture and its prospects for the future. One such group is the Wellcome Trust, who have led an exercise on regional discussions and dialogues. They've identified 3 main areas of focus: governance, clarity and shift power towards regions and low and middle income countries; financing, ensure international financing fits every country's needs; data, knowledge and products, build stronger regional data systems and shape markets to make sure everyone can get the health products they need. They've articulated some of the strengths of global health: the normative function of WHO, technical cooperation to leverage international expertise, multilateral partnerships, sustained humanitarian presence. And simultaneously, the weaknesses that we see in the current global health: incoherence and inefficiency, power imbalances, accountability gaps, continued external financing dependency, fragmented international health financing, gaps in data sovereignty and knowledge exchange, and fragile and inequitable production and supply. I would say, with the lessons we've learned in the last 2 pandemics, there is an opportunity to weigh into a new global health era. And I would encourage all of us to get in on the conversation about how that new global health era should be shaped. I would imagine if we could keep a vision of a global health that works in partnership with countries and regions, working with national and local communities and stakeholders to ensure immediate, united action to strengthen health systems, ensure equitable access to care, and protect health workers in crises. It includes priorities such as fostering local manufacturing of medical commodities, bolstering pandemic preparedness, and integrating climate action with public health to protect vulnerable populations while advancing health for all. And I'll end on the last, something you can do perhaps, is download the Kigali call to action, which came together at the Kigali meeting last year in Rwanda to really face down this new crisis that we face, but maybe, as Jamie was saying, embrace this new global health era and adopt some of these calls to action. Thank you, Lisa.
Thank you so much, Linda Gale. I think that was such an important reminder of a lot of the positive outcomes and lessons learned during the HIV response. And also the notion that, Sam Friedman in his work talks about how big events can also be moments of opportunity, that crises can be moments of opportunity. So in this critical moment where we're seeing shifts in funding and we're seeing a re-medicalization that sometimes deprioritizes community from the response, how do we take this moment as an opportunity to think about where we want to go in the future? So thank you for that. And Sandra, I'll pass over to you.
Thank you, Lisa. Just wait for my slide to show up. Oh, there, okay. Okay, so I am Sandra Kahanchu. I'm with the HIV Legal Network, and I was invited here today to talk about some case studies of work we do. We work in Canada, that's about half our work, and we also work internationally, providing technical assistance to local organizations that do human rights work, especially with key populations, primarily in Francophone Africa and Eastern Europe and Central Asia. This is my conflict of interest disclosure. And so I just wanted to set some context about Canada's contributions to global health. And last year was a really important moment. We held the G7 presidency, but it was a challenging moment too, because there was a changeover in government. The federal government was in caretaker mode for many of those months. Obviously, there was a significant change in US administration, and globally, we were seeing broad funding cuts to official development assistance. The discourse in Canada, as mentioned before, has really focused on what we can do for Canada, a focus on global security with no mention of public health. And despite an election promise by Mark Carney not to cut our ODA, our international assistance was shamefully cut by $2.7 billion over 4 years, starting in 2026. And most of these cuts are largely targeting health. We're not even close to meeting the 0.7% targets, but we're cutting now. So we focused, along with some civil society coalitions in Canada, organizations, on the Global Fund Pledge, which happened last fall. And this came at a moment in 2022 when we made a historic pledge. Canada pledged at the last replenishment cycle $1.21 billion. So there are big question marks given USAID's dismantling and what other countries were doing. A lot of countries were pulling back from Global Fund pledge, and we had an opportunity to show leadership and fill that gap. So we as civil society looked at inflation over 3 years and said we would ask for $1.37 billion, which would merely reflect what we asked 3 years ago. There's a lot of lobbying, a lot of campaigning, a lot of mobilization, and at the end of the day, our government pledged just over $1 billion over 3 years, and even this modest win was a result of really concerted advocacy by organizations around the country. This is a 16% reduction from our last pledge. So in this context, I asked my colleagues who do the work in Francophone Africa and Eastern Europe and Central Asia to provide me with some thoughts about some key observations they're seeing into context of this global funding cliff that we're falling off. And one thing that they mentioned was that there's increasing laws criminalizing key populations, along with decreased support and funding for those key populations. We see in Senegal, where my colleague Cécile Kazachkine works, in February 2026, 12 men were detained for having allegedly committed offenses of unnatural acts and voluntary transmission of HIV. 1 month later, Parliament voted to impose harsher penalties for unnatural acts, including homosexuality and, quote, promoting or encouraging homosexuality. We've been documenting these cases in the media and with our partners on the ground. We've seen that at least 54 people have been arrested since February. They've been subjected to forced HIV testing, with additional charges for deliberate HIV transmission for those who test positive. And really importantly, this new legislation also prohibits any funding or support for, quote, the purpose of promoting homosexuality. And this has been shutting down discussions of LGBTQ rights, discouraging programs for key populations, and weakening key population-led organizations. And again, from speaking from local colleagues, people are no longer getting their HIV medication. They're too scared to go because of the fear of criminalization. So that was the first observation. The second observation was a shrinking civil space for organizations and key populations. And nowhere is this more evident than in Russia, where one of my colleagues works, Mikhail Galichenko. And there's 3 primary laws in Russia that prevent people from doing the really important work we need to do. There's a law on foreign agents, which was introduced in 2012. This law uses overly broad definitions of, quote, foreign influence and political activity to target any organization receiving foreign support. And as of 2025, over 15 non-governmental organizations providing health services, including vital HIV prevention, have been branded foreign agents, and they've been cut off from state support. The other law, which is even more extreme, is the law of undesirable organizations, which completely outlaws an organization's activities on the Russian territory. And you can see on the screen the number of community-based, community-led HIV response and harm reduction organizations or funders in the region have all been designated: the Elton John AIDS Foundation, the Eurasian Harm Reduction Association, the Eurasian Coalition of Health, Rights, Gender, and Sexual Diversity, the Robert Carr Fund, and the Sex Workers Advocacy Network. All organizations supporting key populations have been deemed undesirable. And what is even more pernicious about this is they are filling a gap that the Russian government will not fill. The Russian government refuses to fund any support services, harm reduction services for people who use drugs, and for sex workers. So this has affected our capacity to do work in Russia. What my colleagues have also shared is that this shrinking funding and repressive legal and political context for key populations and the organizations that support them has led to lack of solidarity, a feeling of burnout, a loss of motivation within communities and the organizations that serve them. The final observation they shared was that these funding constraints have forced a lot of organizations and funders to pivot to quote, life-saving interventions, a focus on HIV treatment over community supports. And one thing I think I've really noticed over the course of this conference amongst the other speakers is the importance of community supports. They are the ones that support community solidarity, resilience, and strengths, which we know are essential for the HIV response. Peer education programs are being cut, and we know how important that is to link people to care and treatment. This risk of massive cuts to human rights interventions and funding means we risk losing focus on HIV in key populations who are going to invariably experience more discrimination when they access services in a mainstream health or social service. So one thing, I just wanted to share a quick case study of one thing where we pivoted in the context of criminalization, shrinking civil society space and pivots to HIV treatment versus community supports. And obviously this is very context specific, but in Kyrgyzstan, where my colleague Mikhail works, paralegal services have emerged as a response to absence of an effective interface between marginalized communities and state institutions. This is a country where key populations are all criminalized and often lack legal identity documents to even access the most basic of healthcare services. So this kind of worked in three phases. It was primarily donor supported. The Global Fund was the one who was supporting key populations to provide paralegal services. So these people are not official lawyers, but they've been trained in legal information support, connecting people to healthcare services, acting as an ally when they're confronting criminalization. In the second phase, the Kyrgyzstan government actually established a formal legal aid system, I think in response in part to the success of these interventions that were primarily donor funded, and it introduced the concept of paralegals within state-recognized structures. The final phase now is that paralegals are now formally incorporated into the Ministry of Justice coordination mechanisms, enabling them to interact formally, and they're recognized with police, courts, healthcare facilities, and administrative systems. So rather than creating a parallel legal system, this approach embeds paralegals within the national legal aid framework, enabling them to act as navigators, intermediaries, and translators of rights into actionable claim. So we've seen we did some documentation of the impact of these paralegal interventions, and we've seen cases where people have had their identity documents restored because of paralegal intervention, allowing them access to healthcare systems. They've resolved discriminatory practices in healthcare facilities, and they've helped people avoid unnecessary detention, which would have cut them off from their HIV treatment. So this is a success story, partially. It's still not state-funded, it's still largely donor-driven, but we think this is a promising intervention that we hope we can scale up. And so that's how we've adapted our technical assistance provision, where we've seen some success with an intervention and a similar legal system. We think that this can be scalable in the region. There's other countries like Kazakhstan and Armenia, which are receptive to the institutionalization of legal aid and a paralegal system. We want to embed interventions into existing state structures and not create parallel programs. And we think this is regionally transferable and scalable across countries facing similar transition pressures. The idea is to embed these effective human rights interventions into national systems before external support diminishes or is already diminishing. So a few key takeaways and priorities for Canada. I think it's obvious, that human rights and public security are complementary. They support one another, obviously. We need to renew our commitment to solidarity and support human rights defenders and civil society more broadly. We need to support multilateral funding like the Global Fund, which does see the value in human rights programs, and that's one of the very novel approaches. And they created a Breaking Down Barriers program that specifically is about human rights interventions. And we need to support the advocacy and community-led responses and services for key populations that are so critical, especially at this time. Especially critical because we know a lot of the organizations that we work with are withdrawing. They're so fearful of being associated with criminalized key populations that they're not doing the work anymore. And we need to support those key populations to continue and sustain that work. Thank you.
Thank you so much, Sandra, for that excellent presentation and really important case study. And I think it echoes what we're hearing from a lot of our community partners in a lot of settings in terms of sort of this critical crossroads of defunding but increased criminalization of key population communities and especially queer communities. And what does that mean when your limited program funding is being further and further cut and you can't provide the necessary services that you've been providing for decades? And I think the case study approach is an excellent one to also remind us of the work done beyond the biomedical. A lot of our considerations are often about administering, as you said, life-saving treatments. And that was the one provision in the PEPFAR stop work orders that life-saving provisions could continue, but there's so much additional work that these community spaces do that make access to life-saving provisions possible. And if we don't fund those spaces and those additional, more structural level supports, we're really going to be leaving communities and people behind. So thank you for that. And then, Rob, I will turn over to you as our final speaker.
Thank you, Lisa. Just waiting for my conflict of interest. I can announce while you're waiting, I don't have any conflicts of interest. I also don't have any slides, which is the first time I've done this in a very long time, so I feel a bit naked without them. But I'm going to really talk about something more of an idea, and I'm a critical theorist, which is perhaps kind of a dangerous thing to put at the end of a session. But I promise to behave. I promised people I would, to some extent. And the notion I'm going to talk about is about viral socialities. And this is the first time I've been at CAHR in person. And I think this notion of viral socialities is not something that's just confined to communities. It's something I think that's spread across the room here over the last few days. So I'm going to come back to that point. So to really speak to the question of Canada's current and future role in global health, I'm going to emphasize my experiences as an anthropologist, a community-based researcher who's been involved in queer and sex worker-led responses that became part of a larger collaboration between Kenya and Canada. And this is really the collaboration that Keith Folk spoke about during his compelling keynote the other night. And this, I should add, collaboration traces back to the 1980s. Now, but before launching into my 7 minutes, I'm checking the time there, I want to acknowledge some of the community advocates, activists, and leaders in Kenya who in many ways could bring across this message more compellingly than me. And to be honest, I just found out 2 days ago that Joshua Kamani is here somewhere. And also, and Joyce Adiambo as well. Joyce, are you still here? So it's kind of ironic. So I'm talking about Kenya, and we have 2 Kenyans who are part of this collaboration. So I'm hoping that you'll jump in at different points and fill in missing details. And I think there's dimensions of this you can really speak to. At the same time, I also want to as I kind of talk about some of these ideas, I want to think about some of the queer rights activists that I've learned a lot from, who've been my mentors, who've made sacrifice to their own personal safety for the good of their communities. Here I'm thinking of Jeff Walimba, Pascal Macharia, who are queer rights activists. I'm also thinking of sex worker activists Joyce Adiambo, Rosemary Kasiba, and John Matenge. I also want to acknowledge, as I mentioned, Joshua Kasami, because he's the clinical director of SWAP. And both he and Joyce, they are part of a collaboration that, as I mentioned, goes back a number of decades. And I'm hoping during the question period they can really speak to some of the points I'm trying to raise. Okay, so like some of the speakers before me, and I really appreciate the comments people are making here. I think to look at this whole idea, and because I want to locate and contextualize this panic, I think, that we all felt around the U.S. Halting of funding that happened very abruptly, which is a kind of the violent part of it, perhaps. And I'm going to provide a sort of a historical perspective, as others have, and just as a kind of a preface, my brief historical approach is an attempt to deny the crisis that the U.S. defunding has created for Kenyan programs. For sure, they place them in tremendous jeopardy. And as Joyce and Joshua can tell you, there have been dramatic impacts on programs that have forced closures to specialized clinics and layoffs to key clinical staff who've been serving communities and that continue to be vilified in Kenyan society. Furthermore, and this is the part I want to emphasize, a once vibrant community-based infrastructure has taken a major hit with the collapsing of peer navigator systems, community-led prevention, education, counseling, and care. So that's sort of the kind of the negative part of all of this. But despite the pervasive and persistent sort of vilification of certain groups of people, and particularly with the political homophobia I'm thinking of here and the criminalization of sex work, historically Kenya has been able to build a long, thriving, sophisticated infrastructure of community-based HIV prevention and care programs across the country, with specialized clinical services and a dynamic network of county-level and national-level health officials that support this work. And they've been a really key part of these networks. And all this is translated into showing tremendous progress with respect to HIV viral suppression. So if you look at the 2024-25 data, 94% of Kenyans who were on HIV therapy have achieved viral suppression. So this is really what's at stake here, and this is what's been jeopardized with the US funding orders. But as we think about the future, about how to pick up the pieces of Kenya's shattered HIV programs, I want to emphasize something that I'm finding is getting increasingly de-emphasized in global public health arenas, not in this space, which is really encouraging me. And that is the vital importance of community-based infrastructure. And so as Lisa and I were putting together this special session, the words of Vin Kim Nguyen, who is a Montreal-born HIV doc, he lives in Switzerland now, and he works here in the summer times, does locums. He talked about, in 2010, about the remedicalization of the epidemic. And he defined the remedicalization, and I'm going to quote him here, as a return to the early 1980s view of the epidemic as a medical problem best addressed by purely technical biomedical solutions, whose management should be left to biomedical professionals and scientists. So Nguyen's comments, or his caution, stemmed from his concern over the statement from the former International AIDS Society president in 2009 at the Vienna conference, which many of you I know have been at. And, you know, at the part of the opening, one part of his statement that he made was, aggressive diagnoses and treatment of HIV should emerge as the most significant theme of the conference, over and above human rights issues. So, in many ways, these words seem somewhat dated now, particularly with the work that Sandra's doing. But I still want to build from Nguyen's comments by suggesting that we have entered actually this kind of late stage in the biomedicalization of the epidemic. And many of these parts are quite celebratory in terms of extension of life and quality of life, and what we hope will be the cure on the near horizon. However, in the global health literature, we certainly know that having effective therapeutics, vaccines, and biomedical technologies does not ensure ready access and uptake, especially for marginalized communities. And there's quite a lot of literature this in medical sociology, medical anthropology. So here I want to suggest, based on what activists in Kenya have been telling me for years, that the history of progress of biomedical prevention and care has also led to a gradual eroding of the vitality of community health networks, which are crucial for building successful public health programs that aim to reach those left behind. In other words, I'm suggesting that the collapse we are now seeing in community-based infrastructure in Kenya is not only immediately due to the halting of US funds, but is part of something that has been brewing for quite some time. When I first traveled to Kenya in 2009, I remember meeting with activist John Matenge, who was mobilizing his peers, a group of young gay men, gay and bisexual men, most of whom were living with HIV, in the capital city of Nairobi. So the group initially met informally in a park they called Avocado Park, where they discussed ways of supporting each other. They shared lived experiences of double stigma, as John called it, of being queer and of living with HIV. So I refer to the formation of these ways of caring for each other in communities as viral socialities, and elsewhere I've defined it as, and I guess I'll quote myself, the spread of intimate ties and solidarities between people as they collectively confront the lived realities of denigration, deprivation, and injustice attached to HIV as a stigmatizing illness. So the viral socialities that emerged through John Matenge's community organizing indeed flourished and became amplified as they joined a larger chorus of community-based human rights defenders, including LGBTQ rights organizations, and some very prominent ones in Kenya you should know about, such as GALC. And also the Kenyan Sex Workers Alliance has also been quite the champion. So this viral sociality also led to the enrollment of 500, or I should say engagement of 500 queer men in this sex workers outreach project that Joshua Kamani is the director of. And it also led to the group's establishment of a community-based organization known as Hoimis, which today stands at over 5,000 in terms of its membership. However, and this is just after watching what was forming around 2009, 2010, and the establishment of the organization. In subsequent years of working with John and his group, I watched how new fluxes of aid, of funding coming from PEPFAR and other multilateral funders were accompanied by new, stricter metrics and reporting requirements tied to clinical attendance. These new reporting requirements seem to siphon energy away from the activist projects that focused on human rights and social justice, leaving community health advocates with less space, less room for the viral socialities that nourished community-based care, and also which, as they built sort of dissident energies, pushed towards social and structural transformation. I soon witnessed how the growing bureaucratization of the response stifled the momentum of community activism. And this is something that they complained about quite a bit. As John and his group became mired in paperwork rather than caring for each other. So the demise of viral socialities, in other words, gave way to the instrumentalization of community participation for the technocratic management of HIV. And commenting on this trend in 2023, a well-known local activist said to both Lisa and I, he said, AIDS activism in Kenya is dead. And he said, the community leaders, we are more like entrepreneurs now. And as he explained this to Lisa and me, it became clear that the intimate ties between community members and their leaders had broken apart, leaving little room for informal modes of caring and solidarity that once mobilized the community. And I'm going to come through this a little bit more briefly. That the other part of this story of the demise of viral socialities involves the global health policy of universal health coverage. And so this kind of ties in with Jamie's talk here. And I'm sure Joyce will have a lot to say about this. But in a nutshell, universal health coverage calls for all people to have access to quality services without financial hardship, in a nutshell. Although UHC as a global health policy discourse was first articulated in the mid-2000s, it has its origins in the Alma-Ata Declaration in 1978 around primary health care. But it was really between 2010 and 2012 that universal health coverage gained its definitive push by the WHO. In Kenya, health officials managing the HIV program became caught up in debates around UHC during and following the COVID pandemic. So according to health officials that were interviewed for a qualitative study that Lisa and I were both a part of, the central concern related to health financing and the goal of becoming less constrained by directives that came from large global funders like PEPFAR, USAID, and the Gates Foundation. So in sum, Kenyan health officials wanted global health aid to contribute to a more streamlined, integrative public health system. So this goal, of course, is laudable from a health system strengthening and post-colonial perspective of Kenya becoming more independent from northern-driven funding imperatives, certainly. However, in these discussions of UHC and Kenya's HIV program, governing health officials began to assert the need for integration of key population programs into the public system, like trying to absorb them in. And I think there may be some resonance with what's happening in Canada here. So the queer and sex worker activists that Lisa and I work with saw this policy shift as highly threatening to their well-being, understandably, and to the ability to access non-discriminatory health services, and deservedly so. According to rights activist Pascal Macharia, who conducted his own qualitative study and were in the process of trying to get his findings published, peers of his who had tried to access health services, HIV-related health services in the public sector, were met with a range of discriminations at the hands of health providers. This ranged from finger-wagging to blatant ridicule and insults. It also brought unwelcome conversion counseling, and conversion counseling is this deployment of religious ideas to reprimand sex workers and queer people. So the point here is that the move in Kenya to assimilate the specialized health services driven by communities not only risked re-stigmatizing groups of people already politically vilified and criminalized, but it also greatly inhibits acceptability of and therefore access to essential health services necessary for HIV epidemic prevention and care. Ironically, it undermines the health for all part of UHC in the name of fiscal responsibility. Important community-based organizations that have clinical programs like the ones run by Dr. Kamani are more than just places where sex workers and queer folks receive biomedical care. These CBOs are places where community members safely gather, see familiar faces, share stories and struggles with each other, offer advice and exchange. These are the spaces where viral socialities once flourished. So I'm going to end here with a question as opposed to coming up with a solution, because I feel like the solution needs to, engage people from different communities. So the question is to actually speak to the main point of Canada's current and future role in global health. And starting from the premise that meaningful community engagement is critical to effective global public health delivery, I want to ask, with Kenya in mind as a case study, how do we approach rebuilding critical community infrastructure without merely instrumentalizing community participation to fit biomedical and global health policy objectives? How can global health research and interventions create more generative conditions for viral socialities to flourish, so that the momentum of community resistance can challenge the structural conditions that inhibit access to essential therapies and prevention resources? I'll end there. Thank you.
Thank you so much, Rob. And I think it was somewhat strategic to have you go last. I know you commented on the position, but I think you nicely articulated with all of the conversations we've been having today. And then very much echoing a lot. As you can tell, we work very closely together on many, many projects in different contexts. And while we're talking about different country case studies, I think the themes that we're hearing resonate in most places, including what we've been hearing about work in Canada in the last few days about diminished funding and what does that mean for the necessary, important, vital community infrastructures that have been so centered to the work that we do within the HIV response. And in moments where we're hearing about more tools in the toolkit with lenacapavir, but totally acknowledging that these new modalities don't administer themselves, right? Communities has always played a center role in terms of both kind of building awareness, sharing knowledge, having the conversations about whether these are interventions that communities want to be taking up. So the idea that we're now immersed in these moments of new biotechnologies, potentially without the community spaces that are so necessary for them to be taken up and successful, really puts us in this critical moment. And when we were planning this discussion, this notion of not having the answers kept coming up, because I think we really are still in a moment of transition. And I know working with people in Kenya as well, what I've been hearing a lot is that, the shock of the 2025 stop work orders, the defunding that followed, people had been waiting for someone to come in and provide a solution. And now more than a year later, it's setting in that nobody has come up with a solution, and it's really time to start moving forward with how do we rebuild the response. So while I know we don't have answers here, I do want to give folks on the panel an opportunity to reflect a bit more about Rob's question about community infrastructure and also any areas of hope for where you'd like us to go next. And maybe I'll go in the opposite order. Rob, I'll start with you, asking you your own question.
That I claim not to be able to answer.
And at the same time, I will prep that we're going to open up to the audience. We have about 10 minutes left. So while we reflect on Rob's really important query, please also feel free to start thinking about your own questions to ask.
Okay, thank you. I'll do this, but yeah. It's interesting, when you walk into the front office of Hoimus, you'll see next to the where the admin person's sitting when you first come in, this banner with, it started off the first year, there was about maybe 4 or 5 funders, and then over the course of 10 years, I think there's probably about 20 different funders crowded there. And so there's something encouraging about that there was all this funding supporting, the work that was happening. But at the same time, this meant kind of being so tremendously flexible to be able to afford, because it was this patchwork of really different funds that kind of pulled in different directions. They didn't always line up together. It meant multiple reporting. So to me, to respond to the question, and others can agree or disagree, certainly, it's that there needs to be that kind of recognition that, and the reason why I said community infrastructures, because I think that it needs to be treated by the state, by different governments, not just in Kenya, as a vital part of the public healthcare system. And so with that comes a kind of consolidated, very standardized kind of and steady funding for a little bit more open-ended period of time. Otherwise, it means that they're in positions where they're continually chasing funds and bending things into a way that makes it almost impossible for people to be able to sort of do the work that they feel matters to the community. And I remember that one time we lost a community member who was a staff member. And anybody who knows Hoimus will know that this staff member was somebody who was incredibly important to the community. And they had died by themselves were in their home by themselves for quite a number of days before they were discovered. And it was this moment of awaiting for everyone that somehow, and that's what I think that's probably what underlies my talk about viral socialities. It's like something has, there's been a demise of that. So really having kind of dedicated funding that allows for communities and trusts and respects that communities know what's actually important and that they do the work. And there's, I think, with metrics and with reporting requirements, it creates this kind of relation of suspicion because you always have to prove yourself, right? And so the direction of that it's incredibly colonial in many ways. I'll stop there and let others comment.
Thank you, Rob. Sandra, I don't know if you want to add on in terms especially of paralegal support.
Well, I wanted to speak to the spiral sociologies, this idea which I think I love, and I think that's, for me, in almost 20 years of doing social justice lawyering, the root of all structural legal change comes from community, and we need to, it's not an excuse that we have the dollars, we're funding them in defense and border security in Canada, and we're diverting it from global health. So the dollars are there, it's just a matter of the political will. And actually, when I was doing some research, I wanted to share some really sobering statistics. If we don't fund these organizations that do the key population-led work, this is what's happening. Coalition Plus, which is an international network of community-based organizations, did a survey, and they came out with the results in January 2026 from community-based organizations from 47 countries. And following this USAID funding dismantling, 69% of organizations say they're operating at less than half capacity. 10% of the organizations that responded say they completely stopped any programming for trans people and people who use drugs. 85% of them said they will stop services for men who have sex with men, and 82% of the respondents said they would stop services for sex workers. So it was really sobering to me to see the impact after 1 year, and I would strongly endorse we need to fund these community-based organizations because they are the drivers of structural change in this country and in other places. And we have the money. It's just a matter of political will.
We have the money. We always have the money.
We always have the money.
I want to echo that so many times over. Linda Gale, I see you at the mic. And I also, at the same time, as responding to the viral sociologies, you've invoked activism this morning and again, and I hope you'll speak more to that too as well.
Thanks, Lisa. And just the word I haven't really heard, but I think we've been saying implicitly within the biomedical framing, and I have to confess I'm an outright biomedical person by profession, but I really see the value of viral sociology. I mean, I think it's just an extraordinary concept. But what I wanted to say is the solution here maybe to look at this notion of task shifting? So the one thing, again, that has come out of the HIV epidemic, certainly in my part of the world, has been this notion that health professionals cannot do this alone and that we need to task shift. And in fact, go so far as to say the people that we shift these tasks to do a better job often than the health professionals themselves because of all these intangibles that come with. And I'll quickly just give the South African example. So we received, up until 2025, 1/5 of our healthcare response, HIV response, was PEPFAR funded. Only 1/5, but the biggest amount of money given to any country was that 1/5. When it went away, 15,000 healthcare workers, in the broader sense of the term, were laid off. The majority of those people were not clinicians, doctors, nurses. They were actually these very important people to whom tasks were shifted, and they have now gone away. And just 2 days ago, Becca Ciso, who is a very great activism sort of paper in our part of the world, wrote a piece around lenacapavir is here, wonderful, who will give it out? And to your point, Lisa, I mean, how are we actually going to distribute this lenacapavir? Our investment case has shown the most impactful populations to give len to are pregnant and lactating women and key populations. That's where our government, they've only got 450,000 person years in this limited supply. The best thing we can do, apparently, according to our modelers, is give it to key pops and to lactating and pregnant women. We don't know how to do that, given that those populations all went away. Now, the government is not acknowledging that. When the stop work orders came through, our health minister said, it is no problem. People must just go to the health facilities. There are doctors and nurses there. Integrate. They use that rather now bad word, which we really wish wasn't a bad word, integrate. And people, of course, have really balked at that. It's been really impossible. Gender-affirming care clinics have gone away. With those going away, people are not stepping forward for their prevention and ARV services and so on. And the story goes on and on, even in a country where we fund 4/5 of our HIV response. So where I'm leading with this is I'm wondering if part of this is that we have to speak to our governments, because this cannot only come from international aid. The shame here was that the bulk of our community-led programs were international donor funded, and now they've gone away, and they've gone away. So we have to somehow get to our local governments, to your point, that we need to convince them that this is investment worth making. And I do think that the first hook is around the fact that the people who are doing the tasks have gone away. We've got to bring them back. And then hopefully, the rest will follow. But I think it's really, really important that our own governments are seeing this as an emergency. And I'm hoping it's not when people don't get care. And just again today, Stephanie Nolan has written a piece in the New York Times about how Zambia is falling apart. It's just heartbreaking. Somehow we have to get to our governments on this piece. Sorry, Jamie.
And I think that speaks to the activist part and our asks of ourselves in this room. Jamie?
So, well, thanks, Rob, for sort of challenging and stimulating this conversation as well. I think that unless these processes and structures for providing services and mobilizing communities are seen as essential for the health system and the health services, they're going to be haphazardly funded. There'll be points of light here and there, but the vast majority of people who need those kinds or could benefit from those kinds of services, the activism, the response to the stigma, discrimination, and violence, will not have access to it. You'll have good stories from certain points of light, but unless it's seen as an essential in every health system in every community, there's going to be a long way to go. And for that, I think that I'll go back to something you mentioned, Rob, under the universal health coverage. A very key component of the universal health coverage rubric was the concept of leave no one behind. We can see again and again and again those who are sexuality minorities, criminalized populations, those who suffer from conditions that are stigmatized. Those are communities that are going to be constantly left behind. We have to reflect back to those who are responsible for monitoring the SDGs and others, that there are these communities that are being left behind, not just in terms of their access to HIV treatment, but access to reproductive health, maternal and child health, TB services, vaccination services. How many communities who are men and who are at high risk of HPV infections don't have access to HPV vaccines? So there's a whole range of services where communities are being left behind. So it takes two things. I think one is shifting the framing from a little bit beyond the idea of how will we get a new biomedical technology for HIV to these communities, to how will we provide these communities with the other services that everybody else and everybody should have access to as well. I think it means two things. I think one is we have to shift that framing to say that these communities are not just defined by having a risk or living with a virus. to the fact that there's a human rights component to a wider range of health and social services, but we also need to have design. We need to show how it can be done. We need to develop methodologies for how a program can be designed that builds on the strengths of a community-based response and is able to deliver a wider set of services. Because I know what's going to happen. Newer and newer technological solutions and other shortcuts are going to be provided, even for delivering. So they won't go back to community-based organizations as a way of delivering these drugs. What they'll say is, we'll give them through community pharmacies. We'll give populations apps so they can know when to take the drug, when they should be taking the drugs. That's the direction it's going to go. That will be the response to even a very full-throated advocacy for community-based organizations. So I think we need to show that it can be done and it can work. It can be done at scale, because if you can't do something at scale, it will just be seen as a project. And so I think we have to come up with ways of weaving and interweaving community-based responses into the primary healthcare structure, the community healthcare structure. It's a big challenge, but that's why I think that the HIV community is going to be really critical for that, because that's the one area where I think has really taken to scale community mobilization for delivery of complex health services, prevention and social support and now biomedical treatment. So I think we have to perhaps expand the challenge and look at where there are opportunities even for other funding, rather than thinking about the diminishment of the HIV specific funding.
Thank you so much for that. And I had promised I'd open up to the audience, but we're actually past time. And Raynell, I know you kicked us off. I don't know if you wanted to add anything in terms of the reflections here as well. And I know you had your own ancillary event that sort of took a Canadian focus of global health defunding. So maybe the last quick words.
Thank you so much. I don't have too much to add. Everyone had such wonderful comments. I think I would just like to say kind of another quote that kind of resonates is that distinguishing between global and domestic health is artificial and unproductive in a globalized world. And so I think it's unfortunate that kind of other countries have somewhat taken an opportunity to also continue to pull back global funding at this time instead of stepping up, as we are a globalized world, and this will affect everyone. And so that's kind of how I want to end. Thank you.
It's wonderful. And a big thank you to all of our panelists. I think, as I said before, we weren't looking to solve this particular moment, but I think it is a moment of reflection, and it's a moment for us all to go back into the work and spaces we're in and think about how we build back better and differently, and not forget all of the lessons and all the work we've done before over the last 40 years. So thank you so much for spending lunch with us. Thank you to you all for your expertise.
Thank you, Lisa.
And I hope you enjoy the rest of the conference.